Good evening, everyone. I know people are still joining our event this evening, but we're going to go ahead and get started because we have a full topic to cover tonight. Welcome to our dementia series. This is a series, and I believe, Dr. Tam, we're on number 6, if that's correct, or are we on number 7 at this point in our
I
series?
don't know.
Yeah,
It could be six, could be seven. I
could
don't
be 7.
know.
You might just want to go back and start through them all again if you haven't done that already. But Anthem Memory Care is very pleased to once again bring to you Dr. Tam Cummings. Dr. Cummings is coming to us from Texas, where she is a practicing gerontologist. She has several books that we use in our work at Anthem Memory Care, including the Itty Bitty Dementia book. All of our Anthem Memory Care communities have copies of the Itty Bitty Dementia book. So if you don't have your copy yet, please reach out to your Anthem Memory Care community. And I'm going to turn it over to Dr. Tam, and she's going to talk to us about what does that behavior mean. Dr. Tam?
Thank you, Jamie. Thank you, Anthem Memory Care. Thank you, everybody, for joining us tonight. Remember, this is part of a continuing education series brought to you by Anthem Memory Care. This is part of the training that we put our folks through to help them better understand the care that's required for your loved one with dementia. And tonight, this, as Jamie said, this is a big thing. We're going to talk about what the behaviors in dementia mean? Why did your loved one do that thing that they did? And that thing may be something that's driving you crazy. But before we do, let's start with a couple of things that are just for you, the family caregiver, uh, for the person who's devoted themselves to doing care. Most of you, if you're a family caregiver, you've been a caregiver at least 10 years. If you're joining us now, those of you who are professional caregivers, you may have been caregivers for decades. And as part of doing care, Jamie and I both know we forget to do nice things for ourselves. So just real quickly, we're going to talk about some compassionate touch things. And these are things that we do for ourselves. And these are very important things, very quick things. These are all things that can be done in a few seconds or a few minutes. And they're all designed to help you calm down. So, Jamie, believe it or not, one of the strangest things, and this can sound really, really odd, but one of the strangest things is to first put one hand over your forehead and the other hand over your heart. And the minute you do that, you should immediately feel a calming sense begin to happen through your body. And it should be very quick. It should be something that happens just automatically. And it's because you're giving yourself a connection physically to tell your body that everything's okay. Even though you're very stressed, this is the worst disease a family can go through. Even though you're very worried about everything else, some of you are a sandwich generation. You've got kids at home or kids in college, and you're also doing care for a loved one. I've met people who are in their 70s who are doing care for parents and for a spouse. And so just be aware that takes a toll on you. So hand over the head, over the forehead, hand on the heart. Then move your hand over your forehead down to your stomach and keep your other hand still over your heart. And again, you should feel an immediate release of stress because this is all connected by the vagus nerve. So this is the brain, the heart, the stomach, the upper and lower digestion, all connected on our eighth cranial nerve. And by simply placing your hand on these areas, you can very quickly calm yourself down. Another trick is if you begin to find yourself being overwhelmed, lay down on the ground, lay down on the floor, lay down in a bed, lay down on a sofa, look up. By simply changing the direction in which you're looking at the world around you, literally, you can begin to help yourself calm down. Another compassionate touch, self-soothing activity is to rub your arms. A lot of us are missing touch still after COVID, and the population of people least likely to be touched in our country are older people. And among our elderly, the least likely touched group are people with dementia. Now, as professional caregivers, we're doing our best to do touch for people with dementia, but for you yourself who may be home alone or may not have had a squeeze in a while, rub your forearms, hug yourself, do this tight squeeze because human skin needs touch, even if it is from ourselves. Another little trick is to just put your hands on your face, like the picture of the young man that's on our slide, because this, holding your face the way you would a little child, is again a trick that tells your brain and tells your autonomic nervous system that you're calm, that it's going to be okay, that whatever it is you're going to get through. And then one thing, if you're a dancer, dance like no one's watching. You do not have to go to a dark, smoky bar to dance. You can dance around your house, dance while you're making dinner, dance just because you want to dance. And if you're worried about dementia, dancing is the number one brain exercise that we can give you to do, because dancing causes your brain to move large muscle mass in time to music. So hand over head, hand over heart, hand over heart, hand over abdomen, lay down so that you're not standing and looking or sitting and looking, but giving yourself a different view. Rub your forearms, hug yourself, place your hands on your face, dance. Remember that the journey you're on is very difficult and this is not an easy thing, but we still have to stop and do care for yourself. That makes sense, Jamie? Jamie's
Sorry,
my
I was
person's done.
dancing. Sorry. I was
Thank you,
dancing.
Jamie. I'm glad you already jumped on that. Now, most people are actually amazed to find out that the number one cause of behaviors in person with dementia is untreated chronic pain. And so what you have to remember is every decade of life gives you another level of pain. And when you're in your 50s, you're not in your fifth decade of life, you're in your sixth decade of life. When you're in your 60s, you're in your seventh decade of life. And every broken bone, everything that you ever did to injure your skeletal structure now begins to have the very high probability of arthritis, but you also may have bursitis, tendonitis. There's all kinds of pain issues that begin to affect us as we age. But as people who are aging, we've been taught all our lives to compress pain, to not talk about pain, to not ever mention to somebody else we're in pain. And that has especially been proven to be true in men. When you think about it, Jamie, when a little boy falls down, we go, get up, dust yourself off, be a man, don't cry, wipe those tears away. When a little girl falls down, we all rush over to pick her up and dust her off. So girls get different touch and different messages about pain, but at the same time, when girls begin to have period cramps, no one said, oh, here, let me take care of that pain for you. They told you to suck it up and go to school anyway, because there weren't medications for that. Men have been historically told to shake it off, get up and keep doing what you're doing. And so when you look at your loved one, you should know that every person with dementia has, on average, at least one behavioral issue a day. And if a person has untreated chronic pain, that is 50% of the behaviors that they're having are untreated pain. And people say, well, why don't they just say they're in pain? Well, they don't feel it. You and I have been taught to suppress our pain, and they may not be aware of it, but their behaviors tell you they're aware of it. Another thing is, because of our culture as Americans, we don't talk about pain. It is really a part of our culture. So as you're looking at this scale, I haven't met very many people who have ever said to the doctor, even women giving birth, that they were a number 10, even though right now, while we're talking, if you let yourself actually feel all the pain that you're in, it could be quite excruciating. Jamie, we were taught in graduate school that if we could suddenly feel the average pain of an 80-year-old person, a person who's in their ninth decade of life, that it would be so overwhelming, we would actually scream aloud and fall down. And so we have developed tools, And remember, all the tools in gerontology for dementia are observational tools because a person with dementia has brain damage. They can't truly give us the correct answer. You have to be responsible. You have to be honest with yourself. You know their history better than we do. So we need to know everything that's ever been broken or been hurt or that you're aware of. And then you have to ask yourself honestly, if I hurt right now, how much more will I hurt in another 10 years? And we have to make sure that we stay in front of and aware of pain. Now, pain causes all sorts of behaviors, and they're listed here on this fun little doctor's note that I got one time. Pain causes irritability, anxiety, aggression. Anxiety and aggression also can cause other things that then increase pain. Emotional distress can cause people to feel physical pain. Emotional pain also hurts. There really is something called broken heart syndrome. It causes people to have physical or verbal outbursts, general restlessness, picking. It can cause people to have delusions. Pain can be so severe, Jamie, that a person will not move on into the process of actively dying because they can be so stuck on pain that their body can't relax enough to move forward in the process. Pain interferes with sleep disturbances. Pain can easily be a part of depression. Changes in our sensory perception also cause us to have additional pain. And then the environment and the caregiver. But there's other things that are also part of dementia behaviors, and that's why we may have to use antipsychotics or we may have to go to antidepressants. But the number one and number two causes of pain in people or behavior in people with dementia, the number one causation is untreated chronic pain. The number two causation of behavior is the caregiver themselves. We may have approached too quickly. We're not down in that person's visual area where they can actually see us. We're talking too fast. We've got music on, the TV on, we're chewing gum, there's a radio playing, there's too much disruption going on. We think that the restaurant is still a fun place to go, and restaurants are actually very, very noisy. I could have moved too quickly. I could keep coming back and forth by. I could be saying and not understanding that while I'm talking, this person's agreeing with me, but they're not really understanding me. So we have to look at, first of all, pain. So anytime a community or a family reaches out to me about their loved one or about their resident, the first thing I ask is, has someone done the pain ad scale? Now, the pain ad is available in the back of your itty bitty dementia book. We've put all the tools in there for you. It's available online. This is one of the online tools. All of the tools that we use are available online. It's in the tool section on my website. So we want you to use and understand the pain ad. It's pain assessment in advanced dementia. You also then, after you rule out pain, you rule out delirium, UTI. Has there been a medical event? Is this the progression of the disease? Has there been an undocumented fall with a head strike? Is this grief, depression, or anxiety? And Jamie, you and I both know that we run into families, we run into professionals that don't seem to understand, even with dementia, even with advanced dementia, people still grieve. And that grief may be for something that has happened 50 years ago, but to them is now new, or that grief can be that their spouse of 50 years just passed and no one thinks that grandma's really hurting from that because she has dementia. And that's just simply not true. So somebody can have grief, they can have depression, they can have anxiety, and any one of these things will cause behaviors. But the very first thing we do is we look at for pain. When you look at the pain ad scale, and again, it stands for Pain Assessment in Advanced Dementia. When you look at the pain ad scale, if you're a parent, you're going to look at this scale and go, well, I did that when I brought my baby home from the hospital, because they didn't send you home with a book about how to take care of this baby. But Jamie, within a few days, brand new parents figure out that that method of breathing means I'm hurting. That cry means feed me, but that cry means I want to be held, but that cry means something else is not feel good in my tummy or in my breathing. Facial expression, grimacing, grinding of teeth, vocalizations, body language, either being very stiff or laying very straight and calm, curling up into a fetal position, not being able to console someone either by touch or by voice. And what you realize is you already have, as a human, and especially if you've been a parent, you've already done these things. It's just that we put them together in a scale. And Jamie, even a 1 means that I have pain. And you should know, in gerontology, people are not afraid of dying. People are afraid of dying with pain. And we can control pain. It's just that you have to argue typically with the physician because your loved one didn't tell them they have pain. Your loved one didn't tell them they have pain because they have dementia. They can't tell them they have pain, or they might tell them they have pain, but it's in the wrong area of the body. I knew a nurse once. She was brand new. It was her first night on the job. She was so excited. And a lady in the dementia community and memory care told her that her throat hurt. And all night long, this nurse treated her for a sore throat. And it wasn't until the director of nurses got there the next morning that the new nurse found out when this lady says, "My throat hurt," she actually means I'm constipated and I need to go to the bathroom. So the nurse had been treating the wrong thing. So we now have a tool we use, and you as a family member are going to use that tool because we need you to help us watch for pain for your loved one. Now, families typically at this point, Jamie, will go, "Well, it's okay. My doctor gave my mom PRN medicine," and PRN means as needed. Okay, PRN does mean as needed, but the higher thought about PRN is that PRN means I have a 3-pound brain. I know Jamie's my nurse. I know my hip is now hurting because the weather is changing. I need to go find Nurse Jamie and tell Nurse Jamie to give me my pain medicine. The problem is none of your loved ones have a 3-pound brain. They don't have the ability to do that. In many of the states in the United States, it is illegal for a physician to write a PRN medication for a person with dementia because of that very reasoning. How in the world would this person ever know that they actually have pain issues and that they now need to go ask that person in charge of medicine to give them that medication to help with their pain? The other thing you're going to have to address as families is pain is usually an everyday thing. For example, I have arthritis. My arthritis doesn't occasionally hurt. My arthritis causes pain 24 hours a day, and some days are worse than others because of weather. We joke in dementia care that if you really want to know what the weather's going to be like, ask the people in dementia care because they'll tell you I'm already hurting. And that's because 2 to 3 days before the storm arrives in your area, Jamie, barometric pressure has already changed, and people with arthritis can feel that change because it's changing the fluid in their joints and it's putting more pressure on those areas where there is arthritis. That's why people with dementia are better at predicting weather. You can feel it before it happens. And so what that means is when we're working with our residents, if y'all are in the north, if y'all know, for example, that a snowstorm is coming on Friday, it means on Wednesday, we need to increase the pain medication of the person with dementia so that we are always in front of pain, because we know when that snowstorm gets here, their pain is going to be worse than it normally is. When the weather slacks back off, then we can cut back down to what their normal prescriptive medicine is. Now, Jamie, another thing families don't know, your loved one can have up to 3,000 milligrams a day of ibuprofen, Tylenol, or Aleve. And your biggest pushback is going to be from the physician who's going to say, why that much medicine could hurt their kidneys, that could hurt their liver. They have a terminal brain disease. It is incumbent upon us to make sure they do not have pain. And people with dementia can have narcotic pain medicine. And again, your biggest pushback will be from the physician who's going to say, well, that could make them fall. Well, Jamie, you and I both know they're going to fall anyway because of brain damage. The least we can do is keep your loved ones out of pain. As family members, every 3 months when you have your care plan meeting, you need to come with your pain ad scale and you need to grade your loved one so that we can make sure working with you and the physicians, we're giving this resident, your loved one, the best shot possible at being able to continue to the end of their life without having excruciating pain. Did that make sense, Jamie?
It does, and I really appreciate how much you are emphasizing this point.
Well, it's 50% of our behaviors. If 50% of our behaviors can be handled with Tylenol, let's use Tylenol. Now, this is the dementia behavior algorithm. And I was telling Jamie before we started, I'm not really certain that I've ever given this out to anyone before because generally only gerontologists use this. But in a community and for a family, this is a lifesaver because it forces us to look at the behavior of your loved one and actually go through an algorithm to figure out what is going on. And Jamie, you already know the answer is most of the time it's either going to be untreated pain or something we did as caregivers that was not correct. So first of all, we have to take the problem behavior and decide if it's risky. Now, cursing is part of the disease of dementia. It happens because the side of the brain that contains formal language dies first in most people with dementia, and that leaves them with music, the ability to sing, and the ability to curse. And families can hear their loved one cursing and singing and think that that's actually behavior that has meaning to it, and it doesn't. It just means the brain's trying to communicate, and that's the only area left with words in it. So cursing is not considered risky behavior, but eloping, trying to leave the building, or hitting or striking a caregiver or another resident is considered risky behavior. So if someone said this caregiver or this resident's hitting someone, then we would say, yes, that's risky behavior. And now we begin to problem solve. So as you go to the left side of the screen, you'll see problem solve. Now, first you have to describe the behavior. And Jamie, you should know in my career, the most common thing I'm told, and it doesn't matter what's going on, the most common thing I'm told is that little old lady beats the hell out of everybody all day long. And I know right off the bat, that is not possible because the only thing any of us do all day long is breathe. There is no way a person is in a community attacking people 24 hours a day. So first we have to slow everybody down and find out exactly what is the behavior. Is she really attacking everybody? When she attacks people, is it with a balled up fist? Is she pushing people away? Is she swatting at you? What exactly is the behavior? And once we know what the behavior is, now we begin to ask our first set of questions, which is who did what? What exactly did this person do? What exactly happened? Did she really punch someone in the face with a balled up fist and was ready to hit them again? Did she slap? Did she push? Did she pinch? Did she grab? Was she just saying, get away from me? Was she just screaming? What was the behavior? Where did it happen? Now, in our communities, we're sort of, there's only a few places. We've got bedrooms, bathrooms, dining rooms, living rooms, activity rooms. So it's not like they've got the whole wide world. We can pretty much figure out where the behavior happened. Then when did it happen? And remember, Jamie, we're always looking at when, because when could be a sign of a caregiver that comes on every day at that time and the person has a reaction to, or it could be medicine. But first of all, we do want to know, when does this behavior happen? Because we're looking for some sort of clue to us, some sort of pattern. Is this a behavior that goes on all the time? And then how did the staff member respond to the behavior? What happened when this behavior presented itself? So when we describe behavior, Jamie, it's not the old ladies beating everybody up all day long. It's exactly what happened. You really are being a detective here to find out what happened. Then we move to the other side of the page to brainstorm. And under brainstorming, now we're really looking at the resident. What stage of dementia are they in? And if they're in memory care, it's stage 4, 5, 6, or 7. what type of dementia they have. Certain types of dementia have a more agitated presentation. For example, people with vascular dementia may be more physically and verbally aggressive than people with an Alzheimer's dementia. So different types of dementia can affect a person's behavior. What time of day does this behavior occur? And again, it's for two reasons. We're looking at that. Is it a staff member doing something incorrect? So what I mean by that, Jamie, is a very tall person who does care may not realize that their height alone can cause behavior in a person who has dementia who's much shorter than them. They literally are scaring the person by how they approach, and the behavior is a protection behavior. So we have to, again, look at what's going on with the type of dementia, the time of day, because is this medication or is this a staff member? And for medication, we're looking at typically, it's going to be a behavioral medication, an anxiety medication, an antipsychotic, a depressant medication, antidepressant medication, because it may be that the person has now acclimated to that medicine and they need to have it tweaked or altered or changed slightly or significantly because of the progression of their dementia. We have to do a pain assessment to see if it's something as simple as untreated pain that we've somehow missed. Is there a medical condition we've missed? Has a stroke occurred? Has a fracture occurred? Has something else happened to this person that no one has been aware of? Is there a sensory change? Have they thrown away their hearing aids? And Jamie, you and I know they're going to throw away their hearing aids, their dentures. They may be being forced to wear their dentures, but for several days they didn't wear dentures. And now those dentures hurt because the mouth receded and those dentures don't fit anymore. Could it be something like the person got moved from home to a hospital ER, to a hospital, to a rehab, and now they're in memory care, and in the course of those moves, their glasses were lost. And now the person's behavior is actually driven by something like they can't see us, and that's why they're acting that way. Is there a psychiatric condition that's been missed or hasn't been approached? And then once again, Jamie, we come back to how did the staff actually approach this person? Now, once we have brought all of those answers together, and this is not something that I'm doing on my own, Jamie, or you're doing on your own. This is something we're doing as a team together. I've got my primary caregivers, my nurse there, my activity director is there, my executive director is there, my marketing person is there. I've got everybody brought together to brainstorm on what is happening with this resident so that we can address this behavior. From that communication, we build a plan of action. And then I'm sad for the nurses, but most of these, who's going to do what? It's usually the nurse. Where will it happen? Wherever the nurse tells us to start doing it. How are we going to do it? Once the nurse tells us, we'll do what she tells us to do. When do we start? As soon as the nurse tells us. Who's going to communicate it to the staff? It's going to be the nurse. And then if things are better, we solve the problem. If things do not improve, we have missed something either on our behavior description or on our brainstorming, and we need to go back and go through it again to see what it is that we're missing. Did that make sense, Jamie?
Yes, very much.
So let me tell you my favorite one, and I'm not making this up. I was called by a community to come because the little old lady was beating the daylights out of everybody all day long. And when I got there, I met her and she's a little tiny lady. She's not beating anybody up all day long. So we went through and had the staff describe the behavior. And she wasn't attacking anybody except one caregiver. And that one caregiver was attacked at night in the lady's bedroom. And so then we went over to brainstorm. The lady was in stage 5 of dementia, so she had moderately severe dementia. She was missing about half a pound of brain tissue. She had worked as a CPA, so she was very analytical. She had cognitive reserve. She had Alzheimer's dementia. She was in her 70s. She was not on behavioral medication. She was on a pain medication, and her pain assessment showed that her pain medication was working. She did not have any unusual sensory conditions. She didn't require glasses. She'd never worn glasses. She didn't have cataracts or degenerative vision. She had no hearing impairment, nothing that we could find there. There was no history of a psychiatric condition. There was no evidence of depression or anxiety. So we came back again, Jamie, to the physical approach by the staff. This caregiver was brand new. And this caregiver, this was a group of family-owned communities. They only owned a couple of communities. But this was a new lady working for them, and she was working at night. And of course, we require people to stay awake at night so that if a resident is awake, we have something and someone to do stuff with and someone to engage with the resident until they get sleepy and go back to bed. This staff member, Jamie, had figured out that when she was supposed to make her night checks on people to see if they needed to be changed or to see if they needed anything, because we do that routinely through the night in all communities, she had figured out that if she woke the resident up, then she might actually have to do some work. So she had decided to crawl into the individual apartments, and she would crawl across the floor. She would not turn a light on in the bathroom or in the hall. She would not tell the resident she was in their room. She would instead, from the floor, reach up and underneath the covers, stick her hand and then pat the person's genital area to see if they needed to be changed. Now, Jamie, I find that in my experience, people have two responses when in the middle of the night an unknown hand begins to touch them. Response number one is, well, hey, big boy, hop on up here. Response number two is, I'm being attacked, I'm being assaulted, fight, fight, fight. This lady believed she was being attacked and assaulted. And of course, as I'm telling you this, Jamie, I know you're a professional. You're shaking your head going, this cannot possibly be true, but it was. The person, the caregiver, was causing all of this behavior. But when I got to the building, the entire staff told me, oh, she does this to everyone. But once we did our behavior algorithm, we found out she only did this to one person, and she had every right to be beating on that caregiver. That caregiver was doing something that's so out of the realm of normal that she doesn't work in our field anymore. Aren't you thankful for that, Jamie?
Yes.
She's somewhere in Texas. So go through your behavior algorithm, and it will help you determine what is going on with your loved one, which then helps all of us determine how to do a better job of care for them. Now, there are behavioral triggers that happen, and these triggers are things that we're looking for. They're things that you as a family member may not be understanding as well. And so I'll go through these. One is physical discomfort. We've already talked about that. Pain is 50% of the behaviors in people with dementia, but overstimulation is also a causation of behavior. And that's why there's a point where I tell you, you don't need to take your loved one to a restaurant anymore. The drive is too stimulating. The noise in the restaurant is overwhelming. And so that can cause behaviors. Telling your loved one to go do something because they used to be able to do that very complex task. Everything you and I do is dozens and dozens of steps, and a person with dementia can have a behavior as a response to not understanding what it is you're wanting them to do. Unfamiliar surroundings, and by that, I don't mean an anthem memory care. People with dementia have such extensive brain damage that they don't recognize the home they've lived in and raised their children in. And if you thought they meant the home that they themselves were raised in, you might have even driven them back to that home only be told that's not home either. An inability to communicate causes behaviors. Depression. Remember, in dementia, depression is an atypical form. It's an agitated form of depression. Delirium, which is the brain not able to recognize the brain's chemistry. So the brain is causing the body and the brain to do many, many strange and unusual and even aggressive things because the brain doesn't recognize the brain's chemistry. There can be other medical complications. So every time I'm asked to look at a behavioral trigger, I go back to my behavior algorithm and I ask who was here, what was going on, where did it happen, when did it happen, why did it happen, and how did it happen? And once I get all of those things together, I can then begin to break down what it is that we need to correct. Now, it's not just one caregiver who, for some reason, got it in her mind that crawling on the floor would be a good way to take care of people. We have all kinds of behaviors because of dementias. We have behaviors that are caused by the dementia themselves. They're actually clues to the type of dementia a person has. And then we have other behaviors that share very similar features. So behaviors that we look for that would be dementia related are things like hallucinations, scatological behavior, delusions, those are beliefs that aren't real, lack of empathy or speech, that's a lot of damage in the frontal lobes and temporal lobes, verbally or physically aggressive dementia, that can be happen because of the type of dementia, or it can happen because of damage in the occipital lobe. We see differences in sexual behaviors, falls, urinary tract infections, which also cause behaviors. And then your loved one will begin to have troubles with ADL and become combative with ADL care, because many things that we do in ADL care cause us to do intimate care. So toileting is intimate care, bathing, grooming, dressing, eating is intimate care. So the care that we do for people in and of itself can cause behaviors to happen if we don't pay attention to what we, the caregivers, are doing in terms of how we approach a person, how we talk to a person, how we reach out to the person. Pain, anxiety, and depression behaviors, you'll notice, interlap each other. So first, we always have to rule out pain, but then we immediately look at triggers for anxiety. So you look at the Hamilton Anxiety Scale and you look at the Cornell Scale for depression, because all of these behaviors that are listed here could be pain, could be anxiety, could be depression, could be a mixture of all of them. So somebody who's rocking, Jamie, maybe somebody who was a rocker, so they may be self-soothing, or people sometimes rock when they're in pain, and people also rock when they have depression. Physically or verbally aggressive behaviors, pain certainly causes that. And this, Jamie, really drove home for me one day. I was laying in bed reading, and there was a storm coming, and I have arthritis. And I felt, if you've never had arthritis, it feels like someone is sticking a knife against your bone and twisting it. That's what it feels like to me. So it's not pleasant. And I suddenly felt such a sharp stab of pain, literally, that I screamed out loud. And I have a high pain tolerance. And my first thought was, my gosh, if I hurt like this for one hip, what does an 80-year-old person with arthritis everywhere feel? And you should also be aware if your loved one's back is bent. That's not normal aging. That means that they've actually got thousands of micro fractures in the vertebra of their spine. So people have untreated pain, and we can take care of that. Changes in sleep can be related to dementia, or they can be related to pain, anxiety, or depression. Appetite changes, also pain, anxiety, or depression. And then things that tell you one of these three categories is being impacted, if not all three, is sighing, moaning, grimacing, grinding, kicking, punching, slapping, blinking of the eyes. Jamie, a lot of people don't realize fast, rapid eye blink is a sign of pain. Picking at the skin, a little picking at the skin is maybe self-soothing, but picking at the skin to where I'm actually making wounds on myself, that's a acute anxiety or depression, or again, could be pain, screaming, or even biting at a caregiver. All of those things, we've got to go back and get our tools and look at each tool to determine what is it that's causing this person with brain damage to have this behavior, and what can we do to help modify it. Now, as we go through the dementia behaviors, a hallucination is something you see, hear, or smell. And a person with Alzheimer's can have hallucinations. A person with vascular dementia can have hallucinations. The most common hallucinations we think of are Lewy body dementia and Parkinson's disease dementia. In those folks, these hallucinations can last for hours, not for a few seconds or not for a few minutes. In Lewy body, the four common hallucinations, the person may have one or all of them, is they see children. They see bugs, spiders, rats, or snakes, bad people coming to get them. And Jamie, how many times have you and I seen a person with Lewy body and the bad people coming to get them are actually their own children or their spouse, which means we can't have those people visit till that passes because it's terrifying their loved one. And then the hard one, and this is one that families can forget to tell us about, is that their loved one sees their spouse having sex everywhere. They see their primary caregiver having sex everywhere. Even they can see them through a wall. They can see them, typically it's downtown in front of everybody. A lot of times it's at the grocery store, but they can see their loved one having sex everywhere. And because of the embarrassment of sex, I mean, Jamie, you and I don't want to talk about our parents having sex. We don't want to talk about sex. We don't want to talk about sex with older people. But the reality is humans have sex, and people can be so embarrassed that dad is having this belief about mom that they don't realize that's exactly what the physician needs to hear because it's such a clear marker of a hallucination that comes with Lewy bodies. Parkinson's disease dementia, the hallucinations tend to be more of a double vision type thing, and they're believed to be more related to the medication, the dopamine medication required in Parkinson's, rather than the same thing that's happening in the other dementias. That makes sense, Jamie?
Yes, ma'am.
All right. Now, delusions are beliefs that are not real. And Jamie, this one is kind of hard because for me, a delusion is designed in theory that it's a belief that's not real because I have a 3-pound brain and I've decided you're doing something, Jamie, that you're not really doing. In dementia, people are having delusions because of brain damage. So the belief that's not real, and the most common belief that's not real, is that my family members are stealing from me. My caregivers are stealing from me. And it's actually kind of logical. My brain, which doesn't realize it's sick, and if you try to tell me my brain is sick, all you're going to do is make me angry. That is a human reaction to you questioning my cognitive ability. But my brain doesn't know it's sick. But what my brain remembers is I always put my purse right there. And now I can't find my purse, but Jamie's here. And if Jamie's here, but my purse isn't here, then logically I conclude Jamie stole my purse. Now, Jamie gets upset and goes home. And at 3 in the morning, I find my purse in the freezer. I don't think, oh, I should call Jamie and apologize. I think, oh, I caught Jamie. Look at how she tried to hide my purse from me. You know what? I better go hide my purse before Jamie comes back. And the game starts all over again. So, as professionals, we get told that you, the family, have stolen car keys, wallets, phones, computers, homes, bank accounts, money. And you should understand that we know for the most part, this is the delusion that comes in late stage 4 and stage 5 of the disease, because my brain can no longer make the information to tell me of where I actually put my purse, but Jamie's still here. So it's occurring because of brain damage. But to me, it's very, very real. And to you, the family caregiver, it's very, very painful because you would never imagine doing that. But understand that Jamie and I are professionals, and we do realize that most of the time when you're being accused of stealing, you've done nothing of the sort. But Jamie and I also know that there are people out there that do steal from our elderly, and they certainly take advantage of people with dementia. And so we do have to listen with one good ear and make sure that this is a delusion that they're having and not a reality. Other things that are delusional is the believing that the deceased family member is still alive, and we do not tell them that person has died. They go through the same emotions as they did on the day they found out that person did die. So remember, their reality is our reality. If they're looking for mom, I tell them mom's where mom should normally be. That's where she is. She'll be in later. And then we move on and redirect and go to something else. Other delusional behaviors are that I need to go to work. And this is typically a behavior that we see in men, late stage 5, beginning of stage 6. They know they need to go to work. Women, the delusion that's most common is they need to go get their children. And for women, this is very, very serious. Jamie, I can pretty much talk anybody out of going to work today. Hot water heater blew up. The road is covered in water. We flooded. We flooded here last week. We couldn't get around. Could have had a bridge go out. There's no electricity. It's a federal holiday. You were in the military. It's a government day off. I can come up with a reason not to go to work. Getting a mother to not go get her children is a much different thing because women grew that baby. They know that's their baby. They're that baby's mama, and their job is to go get that child and make sure that child's safe. So this is a much harder redirect for us. And then as the disease progresses into stage 6, the person wants to leave and go home because they now believe that they're a young child and they need to go back to their home. And that's what delusions are. Now, perceptions are things that are often confused as hallucinations because most commonly when people think about a hallucination, they think about something you can see. But in people with Alzheimer's and Lewy bodies and Parkinson's and vascular and any of the other dementias, you have to be able to differentiate between a hallucination, which is something that typically lasts for hours, and a perception issue. A perception issue is that I don't actually see and correctly figure out what's going on. So a common way to think of this is I look out the window. A car drives down the street. The car causes shadow, light, and movement across my window. I have a 3-pound brain. My brain goes, that's shadows, that's car, that's a movement. And then my brain immediately dismisses it because it wasn't important to me. It's nothing that I need. But for a person with dementia, they may begin to tell Jamie that there's actually a person at that window trying to get in the house. And Jamie now has to try to figure out, is that Lewy bodies and this person believes there's bad people trying to come get them in the house? Or was that a perception issue because a car just went by? Other things are televisions. Televisions are now great big flat screen televisions, and a human being on a flat screen TV in a certain shot can certainly look and appear to be life-sized. So we see people with different dementias point at TVs and tell us those are actually people standing over there. And then there are visual changes that occur during the course of dementia. So people with dementia throw their glasses away over time because the glasses no longer work because they can't see anyway. And the visual impairment starts by the loss of peripheral vision, then periscope vision. This is when I now can't see my food, but I can see Jamie's food. So I reach across the table and take her food. Then it becomes binocular vision. Now I'm only seeing these little tunnels in front of me. And it means that if you don't bend over and look in my eyes, all I'm seeing is the middle part of you. And then for some people, they'll lose vision in their left eye. In stage 6, this is called occipital blindness, and they actually only see through a small tunnel in their right eye. So as a family caregiver, you have to help us professional caregivers, especially if you've noticed some of these behaviors in your loved one. Now, scatological events, Jamie, you and I both know nobody wants to talk about these. These are terribly embarrassing to the families. They're afraid we're going to get mad about it. And it's human behavior. Men pee in corners. They've been taught this all their life. Men pee in trash cans because it's a nice round hole. They've been taught to aim for that hole. Men pee on plants because if they were outside, they were told to go stand by those shrubs or go stand by that tree and relieve themselves. People may climb up on their sink in their bathroom and slide across the counter of the sink and then defecate and urinate in the sink bowl. That's not a purposeful behavior. That's somebody that's mistaking that sink for the seat of an outhouse. And you have to remember, Jamie, we didn't have indoor plumbing across the entire U.S. until the mid-1970s. My own mother didn't have indoor plumbing until she was a senior in high school, so that was 1957. I think Arkansas was the last state to get indoor plumbing everywhere. So we certainly still deal with a generation of people that didn't necessarily have indoor plumbing. And then people with dementia can have a bowel movement, feel something going on, reach behind them, and now they've got something icky on their hand. And they're simply trying to get the icky thing off. And they may smear their hand on a towel, they may smear their hand on a wall or on a bed cover, and it's not purposeful behavior. I got something icky on my hand, Jamie, I'm trying to get it off. But if it's alcohol dementia, Wernicke-Korsakoff's dementia, 1 in 4 smear their feces because they're annoyed with the staff, with their caregiver, with their family. Coprophagia, Jamie, is something very rare, very rare. We don't see it very often. This person is usually going to require care in a skilled facility because it would mean that their medical modalities are very, very complex. There's usually a lot of vascular stroke activities going on. Coprophagia is the eating of feces. And so people with dementia can do this. There is a hyperoral behavior that can begin. And if this begins to happen in a person with dementia, nobody's angry with them. We simply have to put them in what is called a backward jumpsuit, and it's Velcroed at the wrist and at the ankles to stop this person from being able to get into their adult incontinent product. You may know it as a diaper, but it's an adult incontinent product, and being able to access feces. So coprophagia is the actual eating of feces, and while it's rare, it is something that happens. It's nothing to be ashamed of. It's all being driven by brain damage. That makes sense, Jamie?
Yes, thank you. Mhm.
And
Yeah.
you're welcome.
Mhm.
Sexual behaviors can be a variety of things. We can see increased and heightened sexual behavior, and that can be stroke induced. That can be the brain producing too much testosterone. Both male and female brains produce testosterone, and in dementia, there can be an overproduction of testosterone. And if we get that, we get somebody who's very grabby or snatchy, or Jamie, we're having sexual behaviors because I didn't know I needed to bend over and look in this person's eyes. And instead, all this person sees are my breast. And so they reach out to grab what they're seeing. We have people with dementia who fall in love with other people with dementia. And what's amazing to me is many of the times when we see this happen, the person they fall in love with also looks very much like their spouse. And they can do this behavior even though their spouse is still alive. And they can attempt to have sex with one another, although many times this is difficult because staff is around. Because folks have brain damage, they may also be on medications that stop the men from getting an erection, or they're simply not sure what to do going forward from there. We have seen people who have lived their lives as heterosexuals with dementia appear to be homosexual in behavior. We do not have any reports of somebody who lived their life as a homosexual who now appears to have only heterosexual behavior. So we assume this is something society-based. A person may have sexual behaviors, Jamie, because they're simply unaware they're in a room full of people. So they may begin to masturbate or try to touch someone else. They could be confused about who a family member is. So my mother may begin to think that my brother is her husband and may think that she's supposed to have him come get in her bed. And that's just a confusion about a family member. And then because of brain damage due to stroke activity, the person may have more difficulty understanding or controlling sexual urges. And then we have medications like Viagra. I certainly in my career have seen men with dementia getting Viagra from their doctor. And that's something the family would certainly, we would want to have a conversation with you about because it's just something that we might agree is not really needed at this point in life. In dementia, you've got to know the signs because some of the behaviors that you're seeing are not behaviors we can do anything about. They're simply part of the disease of dementia. So dementias of the Alzheimer's type. This person is going to constantly repeat and ask the same questions over and over again because the hippocampus in their brain is destroyed relatively early in the disease. And so it doesn't matter how many times Jamie tells them something or I tell them something, they're not able to retain the information. Dementias of the vascular type tend to have more aggressive physical and verbal behaviors and responses to us, especially if we move too quickly, talk too quickly. Lewy body dementia and Parkinson's disease dementia, we see those very distinctive hallucination behaviors. Frontal temporal dementias, we see all sorts of behaviors, typically lack of social skills, changes in language skills, but it is so entirely directed exactly back towards the part of the brain that's being damaged. This frontal lobe is what stops me from saying everything I think. This frontal lobe is what makes me keep my personal space between me and another person. It's what stops me from saying everything I think. But if you really want to know what somebody thinks about how you're dressed or how you look, just go ask people in a dementia community and they will tell you. Wernicke-Korsakoff, they're more impulsive, more snatchy, more grabby, and at the same time, they tend to self-isolate. It's difficult for us to get them involved in doing activities. Huntington's dementia, these folks eventually do become psychotic, and that behavior has to be treated with antipsychotics. And then chronic traumatic encephalopathy, this is called football dementia. It has 4 or 5 domains. The number's kind of iffy right now, but one of those domains is a behavior domain, meaning that this person has aggressive and agitated behaviors. So again, part of the behaviors are coming from the dementia itself. Anxiety behaviors by themselves include things like pilling. Jamie, pilling is when we see people with dementia rubbing their thumb against their fingertips. And if you're watching this now and if you'll do this, this is a human self-soothing activity. And it's because there's still so much nerve impulse coming from the hands and the fingertips. So if I do this a little bit, Jamie, I'm pilling. If I'm doing this all day long, it's become anxiety. If I'm rubbing my thighs or my arms, if I'm doing that a little bit, that's a self-soothing activity. But if I'm doing it all day long, that's anxiety. Picking at the skin is anxiety, and picking at the skin can become the point of I'm actually picking wounds or sores in my skin. Rocking, humming. Jamie, I once had a building call me, and they wanted me to come see them so that I could make a 99-year-old lady stop humming to herself. And my response was, she's 99. She's not bothering a single person. She can hum all she wants. It's a self-soothing activity. It's an anxiety activity. They needed to treat it with anxiety medication. Somebody who's very, very busy. They don't slow down. Their legs are shaking. Their hands are shaking. They're constantly jittering in motion. Somebody who sighs. Well, Jamie, that could be anxiety, that could be pain, or that could be depression. So I got to do all 3 of my scales. Moaning could be depression, could be anxiety, could be pain. Somebody who's withdrawn, we tend to think of a person being withdrawn as being depressive, but that could also be anxiety. And then somebody who's agitated verbally or physically, that could be Lewy body or vascular dementia. That could be the staff or me moving too quickly around the person. That could be untreated pain, anxiety, or depression. Depression in people with dementia does not present the way it does in other people. Depression is usually an atypical form, and the presentation of it is that the person is angry, annoyed, agitated, or aggressive. This is not somebody who's sitting quietly in their room and won't come out and play. This is somebody who's very much can be in our face, and they get treated with an antidepressant. Now, if you're seeing these behaviors, you do the Cornell scale for depression because it's an observational tool. And if your person is on an antidepressant, Jamie, but they still score on the Cornell scale, then it means we need to go back to the geriatric psychiatric person because the medication is either not working, it's not at a higher enough dosage, they need a different type of antidepressant. So we need to let the doctor know that we're seeing these behaviors, and even though the antidepressant is in place, they're still scoring on our scales. And it's the same for pain, and it's the same for anxiety. If they're on routine pain medicine, but they still score for pain, they need a different medicine or they need an increase in it. If they're on an anti-anxiety medicine, but when you do the Hamilton anxiety scale, they still score, then the doctor needs to revisit their anxiety medicine, and the same thing for depression. If your loved one is on an antidepressant but still scores on the Cornell scale for depression and dementia, then it means the antidepressant isn't working. All of the ADLs can cause challenges and behaviors in your loved one, and it's because all of these things are dozens and dozens of steps for you and I to do, and they involve long-term memory. And if somebody's had to learn how to use a walker, that's now short-term memory, and short-term memory is being damaged and destroyed. The piece of the brain that does that, the hippocampus and limbic system, is being destroyed in the course of dementia. That's why trying to keep a person using a wheelchair or a walker is so difficult, because they never in their life did that kind of movement before. Also, if you've never used a walker, it hurts. It hurts your wrist, it hurts your hands, it hurts your upper arms and your forearms to be able to use the walker the way it's intended. Now, people with dementia can use the one that's in the picture, and the most common name they give that is buggy. And they call it buggy because it most commonly resembles a doll buggy that they would have seen when they were growing up. And families, don't be afraid of us. Don't be ashamed of this. We just need to know, does your person have a mental illness? Did they go through their life fighting depression or fighting anxiety, and we didn't have the medicines, we didn't have the know-how, they never got treated for it? Is there alcohol or is there drug use? I ran into someone who has a dementia that is caused by cocaine usage, and it's actually a vascular dementia because excessive cocaine usage caused this person to have strokes. And the family spouse did not want to tell the doctor that until 3 months ago, their person was still using cocaine. You have to tell us. You have to tell the physician. We're not judging anybody. We want to give your person the best treatment possible, the best plan of care possible, and the best physician knowledge possible. We can't do that if you don't give us the correct information. Are they going through nicotine withdrawal? Jamie, I did a grant for the state of Texas once, and they sent me to a skilled facility, and the skilled facility was a 110-bed facility. 87 of the residents were smokers, and they didn't allow them to have their first cigarette until 10 in the morning. So as you can imagine, the behaviors were all over the map because 3/4 of the building smoked cigarettes. And what's the first thing a person does who's a smoker? They have a cigarette as soon as they wake up in the morning. And this building was making people wait for their nicotine 3 to 4 to 5 hours after they had been awoken. So they had to make some adjustments there. Your person may have had a borderline personality disorder that no one ever diagnosed, and now you're having to deal with it. There may have been schizophrenia or a bipolar disorder. We need to know, because that's going to be more like a frontal temporal dementia and not like an Alzheimer's. There may have been sexual abuse in your family. There may have been violence or alcohol abuse or other things that happen. Your loved one may have PTSD. You may have developed PTSD as part of taking care of them. So we're not upset with you. We just want to do the best job we can for your loved one, and we can't do that if you don't give us and the physicians the full background and history of your loved one. You don't need to be embarrassed about it. It's that person. They lived their life the way they lived their life, and there are things they had no control over, but we need to know now so that we can do the best care possible for your loved one. Now, there are behaviors that are challenging, and these can be things that are physical or verbal attacks. It can be hard to be a caregiver for your loved one if they just seem to be annoyed at you all the time. They resist care. They seem resentful of care. Or they actually hit you, bite you, slap you, pinch you, grab you. And you should know that if somebody with dementia grabs you, you've probably figured out by now, just because a person has dementia doesn't mean they don't have strength. But your easiest way to break the grip, if you do get grabbed and you tell them to release you and instead they grab harder, that's just brain damage. They're not trying to grab you harder. You can break it where the thumb and finger come together. That's the best point to make a break. The other thing is to redirect this person. And of course, my favorite redirection is a Hershey kiss, because how can you possibly be mad at me if I'm trying to give you chocolate? So understand that being suspicious, being confused, arguing with you, being resentful, resisting, kicking, biting, don't take it personally. These are all things that happen because of the disease process. Now, disruptive vocalization is something that's very, very difficult for us to deal with. And this is when your loved one, what most people see for disruptive vocalization is repetitive questions. And when we do this here, when we do this in a conference, it's I can make this kind of funny that they're asking me the same question over and over again. But the reality is, how many thousands of times today can you be asked the same question before it really begins to get on your nerves? Disruptive vocalization can also mean calling out for help, calling out no. You may go in a community and hear a person screaming, they're hitting me, and there's no one near them. You can see someone screaming, ow, 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 and no one's touching them. But of course, the first thing we're going to do is a pain assessment on that person. Grunting, nonsensical sounds, negative comments, all of these things are verbally agitated behaviors. And then these are believed to be the triggers: overstimulation or understimulation. One of the things that you will notice when your loved one moves into Anthem is most people seem to have a sudden boost in their cognitive state. And it's not because Anthem did anything magical other than they began to do socialization and activities with your loved one all day long, and your loved one wasn't getting that at home. Immobility or restricted movement causes people to call out. So every time you set your loved one in a chair or in a wheelchair, you always do what we do. We make sure their clothing is not wrinkled underneath them, because that can cause pain because it stops blood flow. Any kind of untreated pain or discomfort, being fatigued, especially when they've reached the stage of the disease, stage 6, they can be awake for 36 hours or more at a time. They can have psychotic issues, psychotic symptoms. We can have dementias, FTDs, Huntington's, for example. Those dementias typically are going to have more than one change of antipsychotic medication during the course of the disease. Depression, psychological distress, like missing a loved one who's gone. And then the most common behaviors we see from caregivers, or the caregiver ignores the person or they ignore the behavior. My favorite one is that they tell the person to be quiet. My next favorite one is they ask the person why they're yelling. And that's sort of nonsensical, because if this person knew why they were yelling, they wouldn't have dementia and they wouldn't be yelling. If your person is a disruptive vocalizer, they're in a community, the other residents are going to scream at them to stop making that noise. And the first thing we need to do is look at medications. So when we have severe disruptive vocalizations, this is something where the noise persists for hours each day. And this is extremely stressful on you. We believe it has to be stressful on your loved one. It is very stressful for the staff. It's stressful for the other residents. And typically, this person is not going to respond to typical behavioral or medical interventions, or they don't respond consistently. We have to look at these people on a very individualized basis. We really have to come together with our behavior algorithm, with our family history of what this person was like, and then just our knowledge to figure out what is going on. And this is believed to be a terminal phase of dementia. But Jamie, I've seen people who had disruptive vocalization for months or for years. And so that's not end of life care. What it turned out on everyone that I've ever seen who has severe disruptive vocalization, most of the time it's untreated chronic pain. But I use this scale, and I found this scale years ago. It's from the University of Iowa's Geriatric Center. And what I love about the University of Iowa Geriatric Center is they will let you go on and look at all of their information, and they've got really, really great stuff on there you won't find anywhere else. This I include because this is the first time in my career I ever found a listing of medications to allow our nursing staff, our families, our professional caregivers to listen to this person's disruptive vocalization and then make a determination. First of all, am I hearing pain? If when I hear the disruptive vocalization noise, I shut my eyes and listen. If anything in that noise sounds like pain, I first am going to treat pain. Then I'm going to come through and look and go, well, does it seem like it's more depressed, more anxious, more psychotic, or do I need to go to these other things? And then that allows us to work with the physicians and the nurses to get your person on the right medication to help with that disruptive vocalization. And then these are the actual medicines that are recommended to be used. And yes, those are antipsychotics, but Jamie, we have to find a way to help families realize we can either not use antipsychotics and your person can spend the last part of their life just going off the scale and being so far away from who they were, or you can let the Jerry Psych doctor do their job and get your person closer to who they were normally through the end of their life. So if you don't, if you have a camera, grab a picture of this because these are the medications that you would be looking at and talking to your physician about. Now, common behaviors in care, is it the dementia? Is it the stage of dementia? Is there untreated pain? What lobe of the brain is damaged? Where is the resident in perspective to the disease? How advanced down in their file cabinet are there? Or did we cause the behavior? Is it something we did? And remember, 50% of the time it's untreated pain, 20% of the time it's something the caregiver did. The other 30% is untreated depression, untreated anxiety, or something else has happened to the person. Now, last time we met, we went through the Bristol scale for the activities of daily living, and you continue to use this scale as your loved one goes through the disease. This helps us, this helps you realize that you're not imagining anything, they are declining. It also helps you help your family and friends understand where they are. It also helps you help the physician understand what's going on. So don't forget to go back and know your Bristol scale. But behaviors that we see come in all these different forms. And your person may have none of these behaviors. It may seem to you like your person has all of these behaviors and we're going to get rid of that person. And that's not true. We do dementia care and dementia care only. That's what we're here for. But we have to go through and look at all these different things to make sure that we're doing stuff correctly and we're getting your person to the best place possible as they go through this terminal brain disease. Now, this picture is probably familiar to you. We used it when we talked about how to stage people and move through the stages of dementia. And as we do that, remember, most of us are stage 1. We're normally aging. We're going to live at home and die at home. We're never going to need care of any type. Dementias are diseases of aging, but not normal aging. Stage 2 is where you, the spouse, first noticed something's wrong and it was very subtle and very quick. Stage 3 is where you worked up the nerve to actually say, I think something's wrong. And then, Jamie, you got your head chopped off, so you didn't ask any more questions about that. Stage 4 is typically when the adult children begin to notice that something is wrong, even though this person still doesn't look sick. It's called moderate dementia at this stage, and the person is fooling neighbors, professionals, families, people at church or synagogue because people think if they're sick, they would look sick, and they've still got great social skills. They can still have that social conversation. So the only person noticing those behaviors is the family caregiver. Then in stage 5, we're at moderately severe dementia. Now short-term memory issues are apparent. Now that repetition of questions is going on and on all day. Why haven't you fed me? When is the doctor's appointment? Why didn't I go to the party? All of those things have already happened. This is when hunting and gathering begins. And hunting and gathering is a behavior of dementia. It means the person is going from place to place to place, finding neat new things, picking them up and moving them somewhere else. And this can make people very angry because they think, well, my loved one isn't doing that. And why is that lady doing it? Well, your loved one is just lucky. It's part of the disease of dementia, and most people are going to go around doing this. Stage 5 is where real accusations of theft begin towards you, the family, or towards us, the caregivers, and still good social skills so they can fool professionals who aren't aware that social skills are not cognition. Stage 6, the person finally looks sick, and you, the family caregiver, finally get support that this person really was sick all this time. And for some of you, it's been years you've been trying to get someone to see what you've been going through. Cursing and singing is a common behavior here, and it's nothing we're upset about. It's just the progression of the disease beginning to be more challenging while we're doing activities of daily living, because so many of those are intimate care in all our lives. You and I've been told not to let people touch us in certain place. And this is also where they're most likely to break a hip. And as Jamie will tell you, as I will tell you, the broken bone and the inability to walk is not because they're not trying. And the broken bone didn't occur because they hit the floor. The broken bone occurred because people with dementia are 6 times more likely to break their skeletal structure. The bone actually breaks when the person stands and turns, and then they fall. So it's not they fell and broke their bone, it's that they broke their bone and fell. And this is also where weight loss begins. And that, again, is a behavior that has to do with the process of the body moving towards death, not with us not trying to give your person their food. Stage 7, the person is bedbound or wheelchair bound, not because they're not trying, but again, because of the disease process. As the disease progresses, the person's inability to move their body becomes such that they drop their chin down onto their chest. And while you're listening to this, go ahead and put your chin down there and tell me if that feels good on the back of your neck. There's now difficulty with eating and swallowing, and language is now mostly sounds or mostly loss, and incontinence of bladder and bowel. And then, even though they're basically immobile, their fall risk goes up because of some sort of internal message we think the brainstem puts out of get up and go. And their risk for urinary tract infection goes up, not because they're trying not to drink fluids, but because the brain runs the body and the brain is damaged. For you, the caregiver, I want you to do the caregiver grief inventory, because one of the behaviors you're experiencing is post-death grief. You're grieving for your loved one as though they'd already died, even though they're still in the other room. I want you to go to selfcompassion.org online and take her test. Dr. Neff is a guru of self-compassion, and you're graded from 1 to 5. I thought for sure, Jamie, I'd score a 5. I think my final score was a 1.3. But she also tells you in the test areas you need to do better to take better care of yourself. Go to compassionfatigue.org. Test yourself for compassion fatigue, which is medically called secondary traumatic stress disorder. Talk to your doctor. You may have post-traumatic stress disorder because of how long you've been taking care of your loved one. Do Zaret's burden interview. That measures your stress level. Go ahead and do the geriatric depression scale and the Hamilton anxiety scale while you're there, and take the results of all of these tests to your physician. We know now, for example, Jamie, that if a person has untreated depression, in about a decade, that becomes Alzheimer's dementia. We don't understand the connection. We just know that there appears to be one. So take those tests and then take them to your physician and do medication. On the geriatric depression scale, that's the one I want you to do for yourself. And Jamie, it's how you felt last week, and it's either yes or no. There is no hemming or hawing or, well, let me think about that for a minute. Well, sometimes it's how you feel right now. And a score of 5 or above is a positive test for depression. In your loved one, you're going to use the Cornell scale for depression and dementia. It's an observational tool. It lets you look at your person and go back to the doctor to show them the results of the test to get them on the proper dosage or the proper medication. Behaviors of the caregiver, you're going through the long goodbye. And one of the things that we forget about the long goodbye is that you're experiencing post-death grief, and it's very real. Post-death grief can cause you to have unexplained physical pain. And Jamie, I don't know if you know this or not, but there actually is something called broken heart syndrome. And you do have, now, when you have someone that you've loved and loved dearly, and it's been a good and fulfilling and happy marriage, it's totally commonplace that their illness affects your own heart health. So please see your physician. If your loved one has a vascular dementia and you're the adult child, you need to go see the doctor and tell them your loved one, your parent, has a vascular dementia and you need to be sent to a cardiologist to be checked to make sure that there's nothing going on with you. Jamie, a few months ago, I asked a family of 3 adult children to go to their cardiologist because of their mother's dementia was a vascular-based dementia. They went to 3 different cardiologists in 3 different states, and every single child came back with something positive for cardiovascular disease that would have been missed if they hadn't asked for a special meeting with a cardiologist. So ask your PCP to get you to a cardiologist, especially if you're having the effects of that or if you're an adult child and your loved one has a vascular dementia. Spirituality in dementia care actually helps with behaviors, reading sacred text, meditating or praying with a loved one, using religious music, gospel music, whatever type of music or hymnals or prayers that they heard growing up, holding religious icons, soothe and help people with dementia and their behaviors. And then familiar spiritual rituals decrease agitation, not only in the person with dementia, but it also decreases agitation in their family caregiver, and it increases the quality of life for the family caregiver and for the person with dementia. The cycle of life, we begin to see different behaviors as the person enters into the final part of their life. And in gerontology, this is called the cycle of life. The cycle of life theory says that I was born in the fall, Jamie, I will die in the fall. My mother is born in the summer, she will die in the summer. My father's born in the fall, he will die in the fall. And this holds true even with people with dementia. The period of time is 30 days before the birthday and 60 days following the birthday. That is the 90-day window. That is the 90-day season. That is the cycle of your loved one's life. And if you're a religious person, whether it's the Talmud, the Quran, or the Bible, each one of these ancient texts speaks about a time to be born and a time to die, that there is season and purpose in life. And after the age of 25, Jamie, about 79% of people die in the cycle of their life. The ones who don't died in an accident, died in war, or had a medical intervention when their death should have occurred that stopped their death from occurring. So, for example, they had a heart attack and were in the hospital quickly enough for the heart attack to be treated. And Jamie, that's it. Those are the behaviors of dementia. There may be a few more, but I think we got most of them covered. What I want you to remember is families, nothing's on purpose. Everything's being driven by brain damage. But by using our observational tools, we can help Anthem Memory Care staff do a better job. We can help our physicians and our other medical providers do a better job. And we can relieve some of the pressure on you because you realize all of this behavior comes from brain damage. Okay, Jamie, that makes sense?
Everything is, yes, so interesting. And I'm sure we have a few questions. I know it's 7:20 Central Time.
I
Do
got a
you
little
have,
excited. I went over. Yeah,
no, do
whatever.
you,
Heck yeah.
all right. I'm looking to see if there are any questions in the chat. If you have a question, please go up to that little chat button and we will put the question, or we'll put the question out there for Dr. Tam.
You know, Jamie, sometimes I do such a good job, nobody has a question. It happens. Okay, that's not true. That doesn't actually ever happen, Jamie, but it could. It could happen. It could.
I'll kick us off. I have a question.
Okay.
I hear this frequently from families who tell me that their loved one is exhibiting a behavior, but then they'll say, but they've always been like that.
So
Especially if it's
dementia, yeah.
yeah.
Dementias don't typically change personalities, but they enhance them. So if I had a type A driven personality, now I got a type A driven personality with dementia. So I certainly can get enhanced behaviors that the family notices these behaviors are more exaggerated than they were in the past, but it's a behavior we've seen before. It's still a dementia behavior. We're still going to go through our tools to rule out other things because Jamie, how many times have you and I seen a person who once we get them on an antidepressant, the family tells us, well, you know, I think they always had depression.
Yeah.
In the 70s, there was no medication for depression. The main thing they gave you was Valium. And if you went
Hmm.
back to the doctor and said that Valium's not working, I still feel depressed, they just gave you more Valium. So antidepressants are relatively new medicines, but any of the behaviors that you see, even if it was an old behavior and now it's just enhanced, we have better medicines now. We have better tools now.
Hmm.
So let us know so we can work with your medical professional and try to get that behavior alleviated or soothed.
We have a question from KB. Is taking things out of the person organizing them throughout the day fall into the behaviors?
What are they?
They're
Is
asking
the
if taking things out of out of their purse,
Oh,
organizing
yeah, they're
them.
just hunting and gathering. Yeah,
Yeah.
they're just
Okay.
hunting and gathering. And remember, Jamie, some people don't hunt and gather, but they Goldilocks.
Hmm.
Goldilocks goes from room to room to room in your building looking for a bed that's comfortable. And when she finds the right bed, she takes a nap. And when she gets up, she moves on about her hunting and gathering. But it's a normal behavior to occur. What's, I think, aggravating for you and me, Jamie, is we run into people in our field who have communities and they try to punish people with dementia for hunting and gathering when hunting and gathering is a normal thing they're doing. Why would we try to punish someone for that? They have brain damage. They're just looking for pretty things. And then they take them and hide them somewhere else. And that's why we tell you don't bring the good jewelry. I've seen jewelry in a building that was supposed to be in that room down there, and it's way on the other side of the building in the bottom dresser drawer of somebody else's
Hmm.
dresser because they're hunting and gathering. It's just a common behavior that humans are doing.
And we actually provide opportunities for individuals to do some of those things throughout the day by having
Absolutely.
things like purses with things in them for
Hmm.
them to
Hmm.
organize. Steve is with a group, I think, in Wichita, and a question is, can Depakote be given to a patient who needs to be fed?
You'd need to talk to the physician about that. Typically, they would use a Depakote sprinkle if there's a problem with swallowing issues, but that would be a
Mhm.
physician question.
Okay. And then Steve's group also wants to know who do they go to for medications? This psychiatrist, nurse practitioner, maybe their general practitioner. I think
It
you've
is
mentioned Jerry Psych a few times.
Yeah, it typically the way the system is set up is a neurologist specializing in dementia does the dementia medications and a geriatric psychiatrist does the other medications. And then in y'all's communities, your medical directors usually have certification in geriatrics or internists. They have some sort of background in geriatrics in order to be your medical provider. So when I get calls from different parts of the country saying, where do I place or I can't find a doctor, I tell them, call the closest memory care building and ask the marketing
Hmm.
staff. They know every good doctor in town. So they will know who to send you to help you in your area. But it's usually going to be a Jerry Psych person who does the mood medications.
Okay. We have a question. My dad has been yelling and crying out after dinner, usually around 5 to 5:30. It lasts for 10 minutes or so. How should we speak to him when he does this to help him?
First of all, you want to document that. You want to document what time that is happening, what happened right before, how long the behavior went on, specifically what did he do, because that's what the doctor needs. That's what we would be doing in a community, right, Jamie? We'd be
Yeah.
making a behavior log of when does this occur, what happened right before, what happened during, what happened right after. If it's only for 10 minutes and you mentioned food, my first thought was he needs to go to the bathroom. When was his last bowel movement?
Hmm.
So one of the things that we have to ask you about is how often does your person have a bowel movement? Do they have a bowel movement right after breakfast? Do they have bowel movement once a day, twice a day, 3 times a day? Do they have a normal bowel movement every 2 days, every 3 days? Or has a change in medication caused somebody to suddenly have constipation or actual impaction? And then remember, Lewy body and Parkinson's have constipation as part of their dementia. So I would do a behavior log on your dad and put down the times that the behavior is occurring and what foods he was eating, how the foods were prepped, but try to find what is the common denominator that's going on, because that's the first thing we would do. We would start a behavior log to see what is going on in this person. Use your behavior algorithm, and you should be able to figure it out or go to the physician with better questions.
Okay. We have a clarification on the Depakote question. It was actually for FTD. Is Depakote good for FTD?
The frontal temporal dementias get probably the more antipsychotic medication than others forms of dementia do, but it's because of their the areas of the brain that are going under such massive damage. So if the physician has ordered Depakote, there's a reason for it, and I would be asking the physician.
Okay.
When physicians give an antipsychotic, Jamie, every 3 months, every quarter, when you and I have care plan meetings for that person, the physician has to make has to do a writing in the chart of why is this antipsychotic still being used. So they're paying a lot of attention to antipsychotics. Good physicians don't mind you asking at all, why did you select this medicine? So just ask the doctor.
Okay. I am really interested in your answer to this question, or response to this question. Mom no longer wants to put her clothes away and she wants them in piles on her bed. Is this due to her not wanting to forget where her clothes are? She always wanted clothes in the right place, for example, her closet or drawers.
She's missing the steps. If you look at putting away clothes as steps, she knows to take them from the dryer and put them on the bed. And then at the bed, you start folding them. And then from folding them or hanging them, you then put away. It's no different than any of the other steps. She's got one of the steps down. She's missing all the rest of them. She's not able to think of, oh, I'll do this to mess with people. They're missing steps. Pieces of their files are being pulled out due to the disease process. So imagine the brain being like your home office. If I came into your mother's home office and I took 6 of her electric payments, 3 of her mortgage payments, 2 of her insurance payments, all of her car payments, and then I yelled at her to go find those payments, she can look all day, she won't find the payments because they're gone. Your mother's doing part of the task, but she can't find the steps to the rest of the task. So it's not anything on purpose. She's just doing a behavior she's always done. She just no longer has the capacity to do the rest of the steps for the behavior. And it's noticeable to you because your mom was so dress right dressed and kept everything so neat. And so we would want to keep things neat for her.
There you go. Several thank yous to you, Dr. Tam, in the chat for once again providing us with so much great information and sharing your knowledge. And if there aren't any more questions,
Okay.
7:30, we're going to call it a night, but please make sure you reach out to Anthem if you are looking for a copy of the Itty Bitty Dementia book, or you would just like to discuss your situation and how a memory care community might be of benefit to you now or in the future. We're always open to starting the conversation at whatever point you are at in that journey. We are here to support you, and reach out if you're looking for a support group. We either have one on site or we'll help you find one that suits you best. Dr. Tam, we're looking forward to next month with you once again.
Yes, I'm going to be in Cincinnati with Amanda, and I can't remember her executive director's name. So I'm not even going to say it. I'm going to say the wrong thing. But I'm very much looking forward to being there. We're going to be there a day to speak, and then I'm going to actually spend a couple of days in the community. So if families want to meet with me and Amanda, we're going to be there, and we'll be there to help you. And if you're going to meet, you need to make that appointment with Amanda in her community. And you need to plan that talking with me is about an hour to an hour and a half, because I need to know your person's whole history so that we can pull everything together for you to figure out where they are now.
Well, the fortunate people that will get to do that with you in Cincinnati with Amanda and Craig. And then we'll be back again with Dr. Tam on June the 12th at 6 p.m. Central Time.
I'll be in Cincinnati at that point, actually. Yeah.
All right. Thank you.
Come to you live from Cincinnati that night. Absolutely.
Hope you all have a very enjoyable Mother's Day for those out there that will be celebrating and recognizing Mother's Day as well. Everybody have a good evening. Thank you.
Thank you, Jamie. Thank y'all. Thank you, Anthem. Everybody hang in there.